Welcome to Ask Dr. Murphy, This Week in Public Health. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Doing well. Good morning.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. Today, Dr. Murphy will be addressing the latest headlines submitted through today, June 26th, and we welcome any questions or comments down below or at any of our social media linked in the description. Starting today with a newly published study about last year's COVID vaccines and their efficacy. Dr. Murphy, can you break down the findings?
Yeah, everyone, we bring this up because a lot of people I hear regularly is that, oh, COVID is over. Don't worry about COVID. Don't take the vaccine. Don't worry if you get it. The usual. However, if you look at the data, COVID is not gone. This study, which was published in JAMA Network Open, respectable journal, found that in 111,000 adults that were followed, that those who had been vaccinated were 50% less likely to end up in the emergency department, urgent care, or be hospitalized due to COVID. So this is just, 111,000 people. That's a lot of people. This is a big, very powerful analysis. This was analyzed from, like I said, 111,000 adults across 7 U.S. states, so it's not limited to any one particular state. It's a variety of states. And if you look at last year, so the flu season, the respiratory season from fall 2024 to 2025, they were somewhere between 390,000 and 550,000 COVID-related hospitalizations. This is like 500,000 people. This is like gigantic. And of course, it's mostly in adults over 65 or anybody with a pre-existing condition. Those are the ones that are at the highest risk. So COVID is not over, and the vaccine does help you.
Precisely. And we've talked a lot about some of the side effects of COVID infection that can be long term. Heart problems and another study published very recently found even more side effects. Can you tell us what they are?
Yeah, this is a long-term follow-up study in 770,000 military health beneficiaries. They have really good centralized medical records. They know everything going on with those people. It's basically like how the European countries look at all their healthcare because they have everything is centralized. We do the same thing with Medicare. Medicare has the same kind of data, and we have different databases, but just so you know the difference. This is military data. And they found that if you had a COVID infection, you had a significant increase in ultimately developing asthma, rhinoconjunctivitis, infection like irritation around the eyes, food or medication allergies, urticaria, which is hives, and atopic dermatitis, kind of a skin condition, up to a year to two after the infection. The strongest association was with asthma, with a 54% increase in adults and 82% in children, suggesting COVID has an outsized immunologic impact on the respiratory tract. And so this is just another reason why you don't want to have COVID. COVID hasn't gone away. COVID is out there, and there's a lot of these long-term side effects that are really serious. So try not to get COVID.
Yes, and we will keep reporting on these studies as they come out.
Mhm.
Now, some really good news is that the mRNA flu vaccine has finally seen some positive progress. Can you tell us about it?
Yeah, this has been a strange, long and winding road. So Moderna, the maker of the mRNA COVID vaccine, has also made an mRNA flu vaccine. And it turns out, in a big study of 41,000 adults, it was 27% better efficacy against flu-like illnesses compared to the standard vaccine, which is better than nothing. All right. So from nothing to the regular vaccine to this is an improved, more potent vaccine. So the committee at the FDA that reviews these studies voted unanimously to approve this mRNA flu vaccine for people 50 to 64 and an accelerated approval for those over 65. Those are the ones that suffer the most from the flu. So if you remember, when they finished the study, which was very expensive and had those 41,000 people in it with, getting the regular vaccine or the new mRNA vaccine, the director of the FDA didn't even want to review it. He didn't want to send it to the committee. So finally, it wound its way to its advisory committee, and they approved it unanimously. So that's where we are. And I really think it's a very well designed study with a very good comparator. And basically, we've developed a better mousetrap. It is a better vaccine. So it has to be signed off and formally approved and then marketed. So hopefully this is going to be done before the flu season. I'll tell you one thing, in the fall, I'm going to take this one. But take anyone. Anyone is better than none. And I believe that this is absolutely real, and I'm going to take it.
Yeah, it's really great news. But some unfortunate news is that we continue to follow the Ebola outbreak in the Democratic Republic of Congo. Can you bring us the latest numbers and news?
Uh, this is pretty sad, actually. This is a new form of Ebola caused by the Bundibugyo strain, which may be a little milder, but still kills people. The total confirmed numbers, which are probably way lower than reality, are 1,155 and 304 deaths. This makes it the largest confirmed case count ever recorded in the first month of an Ebola outbreak in Africa. So, looking just historically, we're in trouble. Um, the WHO announced a clinical trial they're going to help sponsor, looking at remdesivir, which is used for COVID, and a monoclonal antibody that's been developed to treat Ebola. So that's good. And hopefully they can get this thing under control. So there's a couple, and there's also been, you may have heard about the French doctor who was working down there, came back, and then got diagnosed with Ebola when he got to France. Not before he left, but when he got there. He exposed some people on an Air France plane. They are in quarantine, and he is in a hospital getting treated. So that's just the one person. So anyhow, Ebola, this is likely really going to be bad. Now, we talked about it last week a little bit, but the EU and even the United States has actually started contributing significant amount of money. The African CDC and other health officials in the region think they're going to need about $1.5 billion to actually get this thing under control. And they've got clinics set up. Now they've got this clinical trial. They're making the diagnosis better now. They're doing what could have been done over a month ago. So you remember the diagnosis was delayed because the original test doesn't work for this strain. So that's unfortunate. But anyway, it hopefully this thing can get it's going in the right direction at this particular point, but we got to be on top of these things or we're in trouble.
Yes, absolutely. And we will continue to follow the case numbers and the response to the Ebola outbreak.
Mhm.
But here in the US, we still have rising measles cases and a comparison between different responses to measles outbreaks. Can you break it down for us?
Yeah, so we're up to at least 2,134 cases with 136 hospitalizations and 3 deaths from the measles outbreaks that began in West Texas earlier or late last year. Utah has really had trouble fighting the outbreak with cases in 22 of 29 counties. I mean, it's really out of control. And they've confirmed 680 cases in the state. There are, have been big blips in Texas, South Carolina, and Arizona. And a single wrestling championship exposure in February sparked 46 cases. And it's just out of control. Now, compared, Illinois, we had an outbreak in an immigrant facility where people were being forced to stay, and that was fixed. This is like already almost 2 years ago. And then there was a small outbreak in Cook County in the fall of 2025 when an unvaccinated 4-year-old arrived from a country that has endemic measles and spread the virus in an emergency department waiting room, exposing 99 people across 2 visits. Highly contagious. Remember, measles, super contagious. So there's just this one case. There may be a second case. There are people being observed at this particular point, but it doesn't look like it's spreading around the state. It doesn't look like it's spreading around the city. And I think it's because we have better herd immunity here in Illinois. And we've got the health department is doing a great job. So there's a big difference between states like Illinois and Utah and South Carolina. And I think this is showing what can be done. But it's just so much easier to prevent this thing with the vaccine that's been out for over 50 years. And hopefully people will take, if they don't want to get sick, their kids sick, it's vaccine works really well.
Absolutely. Up to 97% effective for 2 doses of the
Right.
measles vaccine.
Even one dose gives you 93%.
Yeah, really, really effective. And some more good news is that the US has ended the Hantavirus watch for those who were in quarantine.
Yeah,
Can
this
you
is
break that down?
another good story coming to an end here. So CDC officially ended the hantavirus response after all 18 US residents who were in quarantine and everything hit 42 days. They let them go and they've closed the whole program. So it ended up that hantavirus was only spread to people on the ship. Nobody else, they did not spread anything to anybody, even though they were leaving the ship and flying to different countries and showing up in emergency rooms in Johannesburg and other cities. Flight attendant got sick, but it turned out she didn't have hantavirus. Can mimic the symptoms of other diseases. So that's really good news.
Very, very good news. And unfortunately, our last story today is not good news. The US government here seems to be ending PEPFAR funding for the country of South Africa. Can you speak briefly about HIV's impact in South Africa and why this funding isn't going there anymore?
Yeah, so South Africa is it's a very unique country. Um, it's got, I'm not sure the exact population, 50 to 60 million people, I think. I have to check on that for the exact number. But they have the largest number of people infected with HIV in the world. They have 8 million people living with HIV. That's the highest in the world for a country. And the country's not that big. I mean, like Nigeria has over 200 million people. All right. Uh, you know, India and other countries, they've got way, way, way more people than South Africa. South Africa is an important country. It has one of the biggest economies in Africa, and it has the most diverse economy in Africa. They manufacture, they've got agriculture, there's a lot of things about South Africa that are very positive. And our current government has pulled out all funding for them, and PEPFAR was the last thing there, and now PEPFAR is going to go because of the president's concerns about the treatment of its white citizens. And this all goes back to Elon Musk and his crankiness about South Africa. I go to South Africa regularly, all right? I don't see any white people complaining about anything. And I mean, I go there. I work with the people there. I work with everybody there. Black people, white people, colored people. And no one knows what what the US government is, why they're doing. Well, they know why, but they don't understand. Like, this is crazy. Now, the funding that we give in PEPFAR, the President's Emergency Plan for AIDS Relief, which is just for HIV, accounts for 17% of the HIV program budget in South Africa. They fund a lot of it themselves, but they get support from the European Union and UK and many other places. But 17% of a big budget to treat, monitor, and diagnose 8 million people is a lot of money. And now there's going to be a big gap. And just that this plan has come out about they're going to cut off PEPFAR has resulted in one agency, Inova Health Institute, has already laid off 3,000 healthcare workers. So, I mean, I just want to put it into the perspective, laying off 3,000 healthcare workers that are focused on treating people with HIV. That's a lot of people. And this is just one institute so far. So anyway, it's just really sad. And they'll adapt, but it's going to hurt. It's going to be painful, and there's going to be some more cases, and you know, it's just not what this country, our country, is really about. I mean, we're not talking about that much money, and for the reason why. But anyway. That's a sad story, and all over Africa as the funding has dried up and U.S. aid has disappeared, and it's very unfortunate. We have quite a few programs there. We're continuing. We're just adapting our funding mechanisms and how we get things done there. And we have a big meeting with our South African colleagues from Stellenbosch University. It'll be at the end of September this year. We're continuing with that and helping them find new funding sources to do their important academic work as well.
Yeah, really, really tough situation there. We will keep our eyes on it as much as we can. But I would like to thank you, Dr. Murphy, for your time and your expertise breaking down all of the important stories this week in public health.
Well, thank you, Katie.
And thank you all for joining us. We hope to see you next week. As always, any questions or comments are welcome down below or at any of our social media. If you'd like to see Dr. Murphy's sources directly in your inbox, you can sign up for his Substack page for free. Link is in the description, and we'll see you next week.